How does continuous glucose monitoring (CGM) compare to self-monitoring of blood glucose (SAG) in terms of patient outcomes and management of diabetes? Answer: continuous glucose monitoring (CGM) and self-monitoring of blood glucose (SAG) are both essential tools for managing diabetes, but they serve different purposes and have distinct impacts on patient outcomes. SMBG involves periodic fingerstick tests to measure blood glucose levels, while CGM continuously tracks glucose levels through a sensor worn under the skin, providing real-time data. Key differences in patient outcomes: real-time data. CGM provides real-time glucose readings, allowing for more frequent adjustments to insulin and other medications, potentially leading to better glycemic control and fewer hypoglycemic events. In contrast, SMBG provides intermittent data, which may not be sufficient for timely adjustments. Glycemic variability. CGM allows for the assessment of glucose variability, helping clinicians and patients identify trends and prevent prolonged hypoglycemia or hypoglycemia. SMBG cannot capture fluctuations between tests. Impact on AC and hypoglycemia. Studies suggest that CGM use can lead to a reduction in HbAC levels and fewer severe hypoglycemic episodes compared to SMBG. However, it requires patient education and device adherence to be effective. What are the differences between a basal bolus insulin regimen and a premixed insulin regimen, and in what situations would each be most appropriate? Answer: the basal bolus insulin regimen and the premixed insulin regimen are both common strategies for managing insulin therapy in diabetes, but they differ significantly in their approach to insulin administration. Basal bolus insulin regimen. This strategy involves using long-acting insulin to cover the body's baseline insulin needs, basal, and rapid-acting insulin to cover glucose spikes during meals, bolus. The basal insulin is typically administered once or twice daily, while bolus insulin is given before each meal. This regimen offers flexibility, allowing the patient to adjust insulin doses according to meal size and timing, making it ideal for patients with type 1 diabetes or insulin-dependent type 2 diabetes who require tight control over their glucose levels. Key advantages: flexibility in adjusting insulin doses, better control over postprandial blood glucose levels, and low risk of hypoglycemia if managed correctly. Key disadvantages: requires more frequent injections and more intensive monitoring, which may be challenging for some patients. Premixed insulin regimen. Premixed insulin combines both short-acting and intermediate-acting insulins in a single injection. It is typically taken twice daily before breakfast and dinner. This regimen is simpler than the basal bolus approach and is often used for patients who have more predictable eating habits and less need for fine-tuned insulin management. Key advantages: simpler to use, requires fewer injections, and is more predictable for some patients. Key disadvantages: less flexible, as the patient cannot easily adjust doses based on meal size or activity level. Appropriate situations. The basal bolus regimen is preferred in patients with more complex insulin needs, such as those with type 1 diabetes, while premixed insulin is often appropriate for patients with type 2 diabetes who have a more routine lifestyle or for those who need an easier to manage regimen. Mrs. Clark is a 65-year-old woman with type 2 diabetes. She has been managing her condition with oral medications but has recently developed a higher HbAC of 9.2%. After thorough evaluation, a healthcare provider suggests adding insulin therapy to her regimen. Mrs. Clark is hesitant about injections and is concerned about the complexity of insulin therapy. What factors should be considered in determining whether a basal bolus or premixed insulin regimen is more appropriate for her? Answer: in determining the appropriate insulin regimen for Mrs. Clark, several factors must be considered. Current diabetes control. Mrs. Clark's HbAC of 9.2% indicates that her diabetes is not optimally controlled even with oral medications. A more intensive insulin regimen such as basal bolus may be necessary to achieve tighter glycemic control. However, the complexity of managing multiple injections could be a challenge for her, especially if she is hesitant about injections. Lifestyle and preferences. Mrs. Clark's comfort level with insulin injections should be evaluated. The premixed regimen might be preferable if she values simplicity and prefers fewer injections. Premixed insulin involves just 2 daily injections, which could be less intimidating. Flexibility needs. If Mrs. Clark has irregular meal patterns or is physically active, a basal bolus regimen might be more appropriate, as it allows for more flexibility in insulin dosing based on her meal size and activity level. Support and education. Mrs. Clark would benefit from counseling on insulin use, including how to inject, monitor her blood glucose, and adjust her doses. Basal bolus therapy requires more education and commitment, so her ability to manage these responsibilities should be considered. Given Mrs. Clark's concerns, a premixed insulin regimen may initially be a good starting point, but if her HbAC remains elevated, transitioning to a basal bolus regimen could be necessary to achieve optimal control. What are the advantages and challenges associated with the use of insulin pumps compared to insulin injections for insulin delivery in the management of diabetes? Answer: insulin pumps and injections are both methods of delivering insulin, but they differ significantly in terms of delivery systems, advantages, and challenges. Insulin pumps: these devices continuously deliver basal amount of insulin throughout the day, with the ability to administer bolus doses at meal times. Insulin pumps are typically programmed to deliver insulin based on the patient's needs and can be adjusted to deliver varying amounts of insulin. Advantages: continuous insulin delivery improves basal insulin control, resulting in smoother blood glucose levels. Bolus doses can be delivered in response to meals, offering greater flexibility in managing food intake. Patients can customize their insulin delivery based on lifestyle changes, such as exercise or illness. Challenges: pumps are expensive, and not all insurance plans cover them. They require patient training and adherence to ensure proper use and maintenance, such as changing infusion sites and monitoring pump function. There may be technical issues, such as pump malfunctions or site infections, which could disrupt insulin delivery. Insulin injections. Insulin injections involve using syringes or pens to deliver insulin either as a single injection, basal insulin, or multiple injections, bolus and basal insulin. This is a more traditional method that most people with diabetes use. Advantages: insulin injections are less costly compared to insulin pumps. There is less need for technical knowledge and device maintenance. Flexibility in insulin types allows for more tailored therapy. Challenges: requires multiple injections per day, which may be burdensome for some patients. Patients must manually adjust insulin doses based on meal timing and activity levels, which can be difficult for some. What is the pharmacokinetic difference between rapid-acting insulin and long-acting insulin, and how does this impact their clinical use in diabetes management? Answer: the pharmacokinetic properties of rapid-acting insulin and long-acting insulin differ significantly in terms of onset, peak, and duration of action, which directly impacts their clinical use in managing diabetes. Rapid-acting insulin. Onset: rapid-acting insulins, such as insulin lispro, aspart, or glulisine, begin to work within 10-3 minutes of administration. Peak: they reach their peak action between 3-90 minutes. Duration: their effects last for 3-5 hours. Clinical use: rapid-acting insulin is ideal for covering meals and controlling postprandial glucose spikes. It should be administered shortly before eating, allowing it to act in conjunction with food intake and providing flexibility in meal timing. Long-acting insulin. Onset: long-acting insulins, such as insulin glargine or detemir, begin to take effect 1-2 hours after injection. Peak: these insulins have no pronounced peak, providing a steady release of insulin over time. Duration: the duration of action is generally between 18-24 hours. Clinical use: long-acting insulin is used to provide basal insulin coverage, maintaining steady blood glucose levels throughout the day and night. It is typically administered once or twice daily, depending on the insulin type. Impact on clinical use: rapid-acting insulin is more suited for meal coverage and controlling postprandial blood glucose spikes. It offers flexibility in timing, but requires careful attention to meal planning and insulin timing. Long-acting insulin provides a consistent insulin baseline, which is crucial for maintaining glucose control in between meals and overnight, but it does not address postprandial spikes effectively. Clinical strategy: both types of insulin are often used together in a basal bolus regimen where the rapid-acting insulin covers meals and the long-acting insulin manages baseline needs. What are the potential benefits and challenges of using artificial pancreas systems in the management of type 1 diabetes? Answer: an artificial pancreas system (APS) is an emerging technology that combines continuous glucose monitoring (CGM) with an insulin pump to automate insulin delivery based on real-time glucose readings, mimicking the function of a healthy pancreas. Benefits: improved glycemic control. APS can reduce HbAC levels by providing more precise insulin delivery based on real-time glucose readings, potentially leading to better overall glycemic control. Reduction in hypoglycemia. By automating insulin adjustments, APS can help minimize the risk of both hyperglycemia and hypoglycemia, particularly overnight or during periods of intense activity. Convenience. Patients with type 1 diabetes no longer need to manually calculate insulin doses for meals or exercise, as the system continuously adjusts insulin delivery. Challenges: cost. The system is expensive and it may not be affordable for all patients or covered by insurance. Technical issues. Like any technology, APS is susceptible to device malfunctions, sensor inaccuracies, or infusion set failures, which can lead to complications if not promptly addressed. Patient education. Effective use of the APS requires extensive training, as patients must learn how to interpret alerts, respond to system warnings, and troubleshoot any issues that arise. Overall, while artificial pancreas systems offer significant potential benefits for managing type 1 diabetes, their widespread use is still limited by cost, accessibility, and the need for patient education and support. How does insulin management differ for children with type 1 diabetes compared to adults, and what are the key considerations when prescribing insulin to pediatric patients? Answer: managing insulin therapy in children with type 1 diabetes presents unique challenges compared to adults, primarily due to differences in growth, development, and lifestyle. Key differences and considerations: growth and development. Children are still growing, so their insulin needs will change frequently as they develop. Basal bolus insulin therapy is often recommended to allow for adjustments in insulin dosages as needed. Insulin needs may increase during puberty due to hormonal changes, requiring adjustments in basal and bolus doses. Dietary patterns. Children may have erratic eating habits, and it can be challenging to coordinate insulin doses with meals and snacks. Close monitoring of blood glucose levels is required to adjust insulin therapy. Hypoglycemia risk. Children are more vulnerable to hypoglycemia, especially in younger age groups. Careful titration of insulin doses, especially basal insulin, is needed to minimize this risk. Insulin delivery. Insulin injections are the standard delivery method, but insulin pumps may be considered for children who need more precise control or have difficulty managing multiple injections. Pediatric patients require close monitoring and ongoing education to ensure insulin management is aligned with their unique needs and lifestyle changes. Collaboration with caregivers, teachers, and healthcare providers is critical in managing insulin therapy effectively. Explain the role of GLP-1 agonists in the pharmacologic management of type 2 diabetes and how they differ from other medications like ADLT inhibitors and metformin. Answer: GLP-1 agonists, glucagon-like peptide-1 receptor agonists, that are a class of medications used in the management of type 2 diabetes. They work by mimicking the action of the naturally occurring hormone GLP-1, which has several effects on glucose metabolism. Mechanism of action: GLP-1 agonists stimulate insulin secretion in response to meals, inhibit glucagon release, thereby reducing hepatic glucose production, slow gastric emptying, and promote satiety, leading to reduced food intake. Benefits: GLP-1 agonists help lower HbAC, support weight loss, and have a relatively low risk of hypoglycemia. They are beneficial for overweight or obese patients with type 2 diabetes and are particularly effective in managing postprandial glucose level SLT inhibitors. Sodium glucose cotransporter 2 inhibitors are another class used in type 2 diabetes. They work by inhibiting the reabsorption of glucose in the kidneys, leading to glucose excretion through urine. While they also lower HbAC, they do not promote weight loss to the same extent and are associated with a risk of genitourinary infections and dehydration. Metformin, the first-line therapy for type 2 diabetes, works by improving insulin sensitivity, reducing hepatic glucose production, and increasing peripheral glucose uptake. Unlike GLP-1 agonists, metformin does not promote weight loss and has a low risk of hypoglycemia. Conclusion: GLP-1 agonists are ideal for patients who are overweight and need both glucose control and weight loss. LT inhibitors are suitable for patients with type 2 diabetes and additional cardiovascular or kidney disease risks. Metformin remains the cornerstone of type 2 diabetes management due to its long-established efficacy and safety profile. How does insulin resistance contribute to the development of metabolic syndrome, and what are the key components of this syndrome? Answer: insulin resistance is a condition in which the body cells become less responsive to the action of insulin, resulting in higher levels of insulin in the blood. This can lead to several metabolic abnormalities, one of which is metabolic syndrome. Metabolic syndrome is a cluster of conditions that increase the risk of heart disease, stroke, and type 2 diabetes. The key components of metabolic syndrome are abdominal obesity, excess fat around the abdomen, often referred to as visceral fat, which is linked to insulin resistance. Hypertension. Elevated blood pressure is common in individuals with insulin resistance and is thought to be due to increased fluid retention and altered sodium handling. Dyslipidemia. High levels of triglycerides and low levels of HDL cholesterol, which is associated with insulin resistance. Hypoglycemia. elevated fasting blood glucose levels or impaired glucose tolerance, which is a hallmark of insulin resistance. Pro-inflammatory state, increased levels of inflammatory markers such as C-reactive protein (CRP) are commonly found in individuals with metabolic syndrome. Linked to insulin resistance, increased fat storage. Insulin resistance results in the inability to properly metabolize glucose, leading to its accumulation in the blood. As a result, the body compensates by storing more fat, particularly around the abdomen, which exacerbates the cycle of insulin resistance. Increased inflammation. Chronic low-grade inflammation, a result of visceral fat accumulation, contributes to insulin resistance and the progression of metabolic syndrome. Clinical management. Managing metabolic syndrome involves addressing its core components, typically through lifestyle modifications such as diet, exercise, and weight loss. Medications may also be used to control hypertension, dyslipidemia, and hypoglycemia. Early intervention is crucial to prevent the progression to type 2 diabetes and cardiovascular disease. When should insulin therapy be considered in the management of type 2 diabetes, and how does it compare with oral medications in terms of efficacy and side effects? Answer: insulin therapy in type 2 diabetes is generally reserved for patients who are not able to achieve sufficient glycemic control with oral medications or other non-insulin injectable therapies. Insulin is most commonly considered when poor glycemic control, when blood glucose levels remain high despite using oral medications or non-insulin injectables, advanced disease, in later stages of type 2 diabetes when pancreatic beta cell function declines and insulin production becomes insufficient, severe hypoglycemia, in situations where patients present with severely elevated blood glucose levels or complications like diabetic ketoacidosis (DKA) or hyperosmolar hypoglycemic state. HS comparison with oral medications. Efficacy: insulin is highly effective at lowering blood glucose as it directly provides the insulin needed to facilitate glucose uptake by cells. It can achieve near normal blood glucose levels, whereas oral medications like metformin, EDLT inhibitors, and ELPA-1 agonists primarily target insulin resistance or other aspects of glucose metabolism. Side effects: insulin. The main side effect of insulin is hypoglycemia, low blood glucose, especially if insulin doses are not adjusted correctly. Weight gain can also occur as a result of insulin therapy, which is an important consideration for patients. Oral medications. Oral medications generally have a low risk of hypoglycemia compared to insulin. However, they can have other side effects, such as gastrointestinal upset with metformin, genital infections with EDLT inhibitors, or weight gain with sulfonylureas. Clinical strategy: initial therapy. Most patients with type 2 diabetes are initially treated with oral medications like metformin. If glycemic control is not achieved, other agents, GLT inhibitors, ELPA-1 agonists, are added, and insulin is considered later if necessary. Insulin initiation. Insulin therapy may begin with basal insulin to provide background insulin coverage, followed by bolus insulin if postprandial glucose control is needed. What is the primary pathophysiological mechanism underlying insulin resistance in type 2 diabetes, and how does this affect glucose metabolism? Answer: insulin resistance in type 2 diabetes primarily arises from a combination of genetic predisposition and environmental factors such as obesity and a sedentary lifestyle. In this condition, muscle, fat, and liver cells become less responsive to insulin, which impairs glucose uptake and utilization. As a result, the body compensates by producing more insulin, leading to hyperinsulinemia. Over time, this compensatory mechanism may fail, contributing to increased blood glucose levels. The key mechanisms include decreased insulin receptor activity. The insulin receptor becomes less sensitive, meaning less glucose is transported into cells. Altered intracellular signaling pathways. Insulin signaling pathways in muscle and adipose tissue are disrupted, reducing the ability of these tissues to take up glucose. Increased hepatic glucose production. Insulin resistance in the liver leads to increased gluconeogenesis, raising glucose levels in the bloodstream even during fasting. The combination of reduced glucose uptake and increased glucose production results in elevated blood glucose levels, a hallmark of type 2 diabetes. Explain the diagnostic criteria for diabetes using HbAC levels and its relevance in differentiating between normal glucose regulation, prediabetes, and diabetes. Answer: the HbAC test measures the average blood glucose level over the past 2-3 months by assessing the percentage of hemoglobin that has glucose attached to it, glycated hemoglobin. This test provides a reliable method for diagnosing diabetes and monitoring long-term glucose control. The diagnostic criteria for diabetes based on HbA are: normal should equal 6.5%. The rationale behind using HbA is its ability to reflect long-term blood glucose levels, offering a broader picture than single-point measurements like fasting plasma glucose (FPG) or the oral glucose tolerance test (OG). It is particularly useful in patients who have irregular eating habits or those who are not able to fast for an OGTT. It's important to note that certain conditions like anemia or pregnancy can affect HbA levels, so in these cases, additional tests like FPG or OGTT may be used for diagnosis. Mr. Taylor is a 55-year-old male with a history of hypertension and obesity. His fasting plasma glucose FPG is 118 mdl and his HbA is 6.1%. According to current guidelines, what is Mr. Taylor's diagnosis and what additional measures should be taken to manage his condition? Answer: Mr. Taylor's FPG of 118 mdl and a HbA of 6.1% place him in the category of prediabetes according to the American Diabetes Association (ADA) criteria. FPG between 100 and 125 mdl is indicative of prediabetes. HbA between 5.7% and 6.4% also indicate his prediabetes. Given that he is at high risk due to his hypertension and obesity, Mr. Taylor should be advised to make lifestyle changes, particularly focusing on weight loss. A reduction of 5.10% of body weight can significantly improve insulin sensitivity. Physical activity: engaging in at least 150 minutes of moderate intensity exercise per week. Dietary modifications: emphasis on a balanced diet, rich in fiber and low in refined carbohydrates. Regular monitoring of blood glucose levels, at least annually, is recommended to track any progression to type 2 diabetes. Lifestyle interventions are the first line of management, but pharmacological therapy, such as metformin, may be considered if lifestyle changes do not suffice in preventing progression to diabetes. Describe the acute complications of diabetes and how they are managed in an emergency setting. Answer: the acute complications of diabetes include diabetic ketoacidosis (DK) and hyperosmolar hypoglycemic state (HS). These conditions result from extreme insulin deficiency and lead to severe metabolic disturbances. Diabetic ketoacidosis (DK) cause: insulin deficiency leads to fat breakdown and ketone production, causing acidosis. Symptoms: nausea, vomiting, abdominal pain, fruity smelling breath, rapid breathing, confusion. Management: immediate treatment involves intravenous insulin, fluid resuscitation, and electrolyte correction. Potassium levels must be closely monitored and corrected to prevent cardiac arrhythmias. Hyperosmolar hypoglycemic state (HSS) cause: severe hypoglycemia without significant ketosis, typically seen in type 2 diabetes. Symptoms: severe dehydration, altered mental status, hypoglycemia, and elevated serum osmolality. Management: similar to DKA, but with a greater focus on correcting dehydration and managing hypoglycemia with intravenous fluids, insulin, and electrolyte replacement. Mr. Robinson is a 62-year-old male with a history of type 2 diabetes. His HbA is 8.2% and he is currently on metformin. He reports experiencing increased thirst and frequent urination. What is the likely cause of his symptoms and how should his treatment plan be adjusted? Answer: Mr. Robinson's symptoms of increased thirst, polydipsia, and frequent urination, polyuria, are indicative of hypoglycemia. Given that his HbA is elevated at 8.2%, well above the target of 7% for most adults with diabetes, his blood glucose is likely poorly controlled. The most likely cause of his symptoms is uncontrolled diabetes, and his treatment plan should be adjusted. Several steps can be taken. Review his current medication. Metformin is typically the first-line treatment for type 2 diabetes if he is not achieving adequate glucose control. Additional medications such as GLP-1 receptor agonists, ADLT inhibitors, which help lower blood glucose and protect kidney function, may be considered. Assess lifestyle factors. Ensure that he is following dietary guidelines and engaging in regular physical activity. Monitor for complications. Regular screening for diabetic complications like retinopathy, nephropathy, and neuropathy is necessary. What is the role of insulin in the pathophysiology of type 1 diabetes, and how does this differ from type 2 diabetes? Answer: in type 1 diabetes, the primary pathophysiological issue is the autoimmune destruction of beta cells in the pancreas, which results in a complete lack of insulin production. Without insulin, glucose cannot enter cells for energy, leading to hypoglycemia and the characteristic symptoms of diabetes. The body's inability to produce insulin requires lifelong exogenous insulin therapy. In type 2 diabetes, the issue is insulin resistance, where cells become less responsive to insulin, leading to a compensatory increase in insulin production by beta cells. Over time, the pancreas can no longer produce enough insulin to overcome the resistance, leading to elevated blood glucose levels. Insulin production is still present, but it is insufficient. Thus, what type 1 diabetes is primarily a problem of insulin absence. Type 2 diabetes involves insulin resistance and eventual beta cell dysfunction. What is the significance of the oral glucose tolerance test in diagnosing gestational diabetes, and what are the criteria for a positive result? Answer: the oral glucose tolerance test is an important diagnostic tool for gestational diabetes mellitus GDA, a condition that occurs during pregnancy when the body cannot produce enough insulin to meet the increased demands of pregnancy. The procedure involves the patient drinking a glucose solution. 75 grams of glucose and blood glucose levels are measured at intervals, typically of 1 hour and 2 hours. The criteria for a positive result for GDM are: fasting glux equals 92 dL if done in the fasting state, 1 hour glux equals 108 mdl, 2 hour glux equals 153 mdl. If any one of these values is met or exceeded, the diagnosis of GDM is made. Management includes lifestyle interventions, diet and exercise, and in some cases, insulin therapy to maintain blood glucose control during pregnancy. Uncontrolled GDM can lead to complications such as large for gestational age LGA infants and increased risk of developing type 2 diabetes later in life. Explain the relationship between diabetes and cardiovascular disease and outline the mechanisms by which diabetes increases the risk of heart disease. Answer: people with diabetes, particularly type 2 diabetes, have a significantly increased risk of developing cardiovascular disease (CVD). Several mechanisms contribute to this increased risk. Hypoglycemia. Chronic high blood glucose levels can damage the endothelium, the inner lining of blood vessels, leading to atherosclerosis, which increases the risk of heart attacks and strokes. Insulin resistance. Insulin resistance leads to increased levels of free fatty acids and altered lipid metabolism, contributing to the formation of plaques in the arteries. Atherosclerosis. Hypertension. People with diabetes are at high risk of developing high blood pressure, which is a major risk factor for heart disease. Dyslipidemia. Diabetes often leads to abnormalities in lipid profiles, including increased triglycerides and low HDL, high-density lipoprotein levels, both of which are risk factors for CVD. Managing diabetes effectively and controlling blood glucose, blood pressure, and lipid levels are critical in reducing the risk of cardiovascular complications. Mr. Davis is a 48-year-old male diagnosed with type 2 diabetes. He is obese and has been prescribed metformin. Despite this, his blood glucose levels remain elevated and his HbAC is 8.4%. What alternative treatment options could be considered and what factors should influence this decision? Answer: given that Mr. Davis' blood glucose remains poorly controlled despite metformin therapy, alternative or additional treatment options should be considered. These include GLP-1 receptor agonists, e.g. liraglutide or semaglutide. These medications help lower blood glucose, promote weight loss, and have cardiovascular benefits. EDLT inhibitors, e.g. empagliflozin or canagliflozin. These medications lower blood glucose by promoting glucose excretion through the urine and have been shown to reduce the risk of heart failure and kidney disease. Insulin therapy. If oral medications do not provide sufficient control, insulin therapy, either long-acting basal insulin or mealtime bolus insulin, may be necessary. Factors influencing the choice of therapy include Mr. Davis. Weight GLP-1 receptor agonists may be preferable for weight reduction. Cardiovascular risk. SLT inhibitors have shown benefits in reducing cardiovascular events and can be especially useful in high-risk patients. Kidney function. EDLT inhibitors are also beneficial in preserving kidney function in diabetic nephropathy. How does the pathophysiology of type 1 diabetes differ from type 2 diabetes in relation to beta cell function and insulin secretion? Answer: in type 1 diabetes, the pathophysiology is primarily driven by autoimmune destruction of beta cells in the pancreas, leading to absolute insulin deficiency. The immune system mistakenly attacks and destroys the insulin-producing beta cells, leaving the individual unable to produce insulin. This necessitates lifelong insulin therapy for blood glucose control. In type 2 diabetes, insulin resistance is the main pathological feature. Initially, the pancreas compensates for the resistance by increasing insulin production. However, over time, beta cell dysfunction occurs and the pancreas is unable to produce enough insulin to overcome the resistance, leading to hypoglycemia. In contrast to type 1 diabetes, insulin production is not absent but insufficient. The fundamental difference is that type 1 diabetes involves the destruction of insulin-producing cells, while type 2 diabetes involves insulin resistance followed by progressive beta cell dysfunction. Explain how nutritional therapy can contribute to the management of type 1 and type 2 diabetes. What are the critical components of a nutrition plan for a patient with diabetes, and how should they be individualized? Answer: nutritional therapy is key in managing diabetes as it helps regulate blood glucose, supports weight management, and improves overall health. For type 1 diabetes, nutrition therapy focuses on balancing insulin doses with carbohydrate intake. Carbohydrate counting and adjusting insulin to meals are essential. For type 2 diabetes, the focus is on managing insulin resistance through weight loss, reducing caloric intake, and eating balanced meals with low glycemic index foods. Key components of a nutrition plan include macronutrient distribution, carbohydrates, proteins, fats, meal timing, and individual preferences. A registered dietitian should tailor the plan to the patient's lifestyle, activity level, and medical history. This personalized approach promotes better adherence and effective glycemic control. ADA guidelines suggest focusing on fiber-rich whole foods, lean proteins, and healthy fats while minimizing processed foods and simple sugars. It's important to educate patients on portion sizes and the impact of food choices on blood sugar. Nutritional therapy also includes managing micronutrient intake, ensuring adequate vitamins and minerals, and avoiding deficiencies. A patient with type 1 diabetes is instructed on carbohydrate counting and using an insulin-to-carb ratio of 1 unit of insulin per 15 grams of carbohydrate. If they plan to eat a meal containing 45 grams of carbohydrates, how much insulin should be administered? Answer: the patient should administer 3 units of insulin. This is calculated by dividing the total carbohydrate intake, 45 grams, by the insulin-to-carb ratio, 15 grams per unit, which gives 45 equals 3 units of insulin. Carbohydrate counting is essential for insulin dosing in type 1 diabetes as it helps match insulin with the amount of carbohydrates consumed, ensuring better blood glucose control. However, other factors such as current blood glucose levels, activity level, and insulin sensitivity may require adjustments to this calculation. For instance, if the patient is experiencing higher blood glucose levels, a correction factor may also need to be applied. It's important for patients to learn how to use carbohydrate counting effectively and make necessary adjustments based on their unique needs and responses. Continuous education about food choices, portion sizes, and how different foods affect blood glucose is essential to empower the patient for better diabetes management. Explain the effects of exercise on blood glucose control for individuals with type 2 diabetes. How can a diabetes educator help a patient create an appropriate exercise plan? Answer: exercise plays a crucial role in blood glucose control for individuals with type 2 diabetes by improving insulin sensitivity and lowering blood sugar levels. A regular physical activity, including aerobic exercise, e.g., walking, swimming, and resistance training, e.g., weightlifting, helps muscles use glucose more effectively. This leads to improved blood glucose levels, better weight management, and reduced cardiovascular risk. A diabetes educator should assist the patient in developing a tailored exercise plan based on their fitness level, preferences, and any complications like neuropathy. The educator can guide the patient on how to monitor blood glucose before, during, and after exercise, as physical activity can increase insulin sensitivity for up to 24 hours, potentially causing hypoglycemia. Educators should also teach patients to adjust their diet, insulin, or oral medications based on exercise intensity and duration. The goal is to find an exercise routine that is sustainable, enjoyable, and safe, ensuring long-term blood glucose control and improved health outcomes. Discuss how a vegetarian or vegan diet can be implemented for a patient with diabetes, considering both the benefits and challenges. Answer: A vegetarian or vegan diet can be beneficial for diabetes management due to its emphasis on plant-based foods rich in fiber, antioxidants, and healthy fats, which help regulate blood glucose levels and improve insulin sensitivity. These diets often include high-fiber foods like beans, legumes, whole grains, and vegetables, which can slow glucose absorption and prevent spikes in blood sugar. However, challenges include ensuring adequate intake of essential nutrients like vitamin B, iron, calcium, and protein, which are typically found in animal products. The diabetes educator can help the patient by recommending fortified plant-based foods and plant-based protein sources such as tofu, lentils, and quinoa. It's also important to monitor carbohydrate intake from plant-based foods such as grains and starchy vegetables to prevent blood sugar spikes. Balancing the macronutrients, carbs, proteins, and fats, is key to preventing both hypoglycemia and malnutrition. A well-planned vegetarian or vegan diet can contribute to weight loss and better blood glucose control when carefully managed. Mr. Wilson, a 55-year-old male with type 2 diabetes, has been struggling with post-meal hypoglycemia despite taking his prescribed medication. He usually eats 3 large meals a day. After discussing his routine, his diabetes educator recommends smaller, more frequent meals throughout the day. Why might this approach help Mr. Wilson, and what other strategies should the educator consider? Answer: smaller, more frequent meals can help Mr. Wilson manage blood glucose levels by preventing large glucose spikes that occur after larger meals. Eating smaller meals throughout the day distributes the insulin load more evenly, which can result in better blood sugar control and fewer fluctuations. This approach also helps prevent overeating, as smaller meals may improve satiety and reduce the temptation to consume excessive portions. Additionally, Mr. Wilson's diabetes educator should consider reviewing his meal composition, ensuring that each meal includes a balance of low glycemic carbohydrates, lean proteins, and healthy fats will help stabilize blood sugar. Educators can also recommend regular blood glucose monitoring before and after meals to track the effectiveness of these changes. Mr. Wilson may also benefit from adjusting his medication regimen if needed, taking medications at the optimal times in relation to meals, or adding light exercise after meals to help lower postprandial blood sugar levels. What are the key principles of weight management for individuals with type 2 diabetes, and how can a diabetes educator support the patient in achieving long-term success? Answer: weight management is crucial in type 2 diabetes management as it improves insulin sensitivity, reduces blood glucose levels, and lowers the risk of complications. The key principles include creating a calorie deficit through a combination of reduced calorie intake and increased physical activity. This may involve portion control, reducing intake of high-calorie foods, and focusing on nutrient-dense, low-calorie foods like vegetables, whole grains, and lean proteins. A diabetes educator plays an important role by helping the patient set realistic weight loss goals, typically 5–10% of body weight, and providing ongoing support and motivation. The educator also educates the patient on healthy eating habits, including meal planning and tracking food intake. Regular physical activity, such as aerobic and strength training exercises, is essential for weight loss and overall health. The educator should ensure that the patient understands how exercise can help manage blood glucose levels and recommend appropriate adjustments to their medication regimen to prevent hypoglycemia. Success in weight management requires a long-term approach that emphasizes sustainable lifestyle changes rather than quick fixes. Explain the difference between glycemic index G and glycemic load (GL) and how each can be used to guide dietary choices for a person with diabetes. Answer: glycemic index G is a measure of how quickly a carbohydrate-containing food raises blood glucose levels compared to pure glucose, which is a GI of 100. Foods with a high GI, such as white bread, cause rapid increases in blood glucose, while foods with a low GI, such as whole grains and vegetables, result in slow glucose rises. Glycemic load (GL), on the other hand, takes into account both the GI of a food and its carbohydrate content in a typical serving size. GL is calculated by multiplying the GI by the carbohydrate content of a food and dividing by 100. A food with a low GL has a smaller impact on blood glucose, even if its GI is high. For diabetes management, it is important to focus on both GI and GL to maintain stable blood sugar levels. Foods with a low GI and GL are recommended as they help prevent rapid blood sugar fluctuations and improve overall glycemic control. How does regular physical activity influence insulin sensitivity in individuals with diabetes, and what adjustments might be necessary for their medication regimen? Answer: regular physical activity enhances insulin sensitivity by helping muscle cells take up glucose more efficiently, thereby lowering blood glucose levels. Exercise, especially aerobic and resistance training, improves the body's ability to use insulin, which is particularly beneficial for individuals with type 2 diabetes, who often experience insulin resistance. For patients with type 1 diabetes, exercise can reduce insulin requirements by improving insulin sensitivity. However, adjustments to insulin dosages may be necessary, as exercise can cause both short-term and long-term changes in insulin needs. A diabetes educator should work with the patient to monitor blood glucose levels before, during, and after exercise and adjust insulin doses to avoid hypoglycemia or hypoglycemia. Patients should be educated about the effects of exercise on glucose metabolism, how to adjust food intake and insulin before and after physical activity, and how to recognize and manage exercise-related changes in blood sugar. Discuss the role of macronutrients, carbohydrates, proteins, fats in the management of diabetes. What are the key guidelines for diabetes patients regarding the distribution of these macronutrients? Answer: macronutrients play a critical role in diabetes management by influencing blood glucose levels and overall health. Carbohydrates directly impact blood sugar and should be carefully managed. The American Diabetes Association recommends that carbohydrates make up about 4.560% of total daily calories, focusing on low glycemic, high fiber foods. Protein is important for maintaining muscle mass and controlling appetite, with recommendations of 1.520% of daily calories coming from lean protein sources like chicken, fish, and legumes. Healthy fats, monounsaturated and polyunsaturated fats, help improve heart health, a key concern in diabetes. Fat intake should make up around 2.535% of daily calories. A balanced diet that includes these macronutrients in appropriate proportions helps maintain stable blood glucose levels and supports overall health. The diabetes educator should assist the patient in understanding portion sizes and how different foods affect blood glucose. Regular monitoring of blood glucose levels can guide adjustments to the macronutrient distribution for optimal control. If a patient with type 2 diabetes is planning to start a regular exercise program, what changes might need to be made to their medication regimen, and how can the diabetes educator assist? Answer: starting a regular exercise program can enhance insulin sensitivity and lower blood glucose levels, potentially requiring adjustments to medication. For patients on oral medications, such as metformin, the educator should ensure that the patient understands how exercise impacts blood glucose and may necessitate reducing medication doses to prevent hypoglycemia. For patients on insulin, the educator should discuss potential insulin dose reductions, especially for those who experience increased insulin sensitivity due to exercise. The educator should also advise on adjusting the timing of medication in relation to exercise, such as avoiding insulin peaks during exercise or taking smaller doses. Blood glucose monitoring before, during, and after exercise is crucial to ensure safety and to identify any trends or patterns that require medication adjustments. The goal is to help the patient balance their medication, exercise, and nutrition for optimal blood glucose control while avoiding hypoglycemia.